Hi, I'm Peter Lichtenberg, Director of the Institute of Gerontology and Professor of Psychology at Wayne State University. Delighted to talk to you today about improving accuracy in cognitive screening or testing with African Americans. I have nothing to disclose. Key terms today really cognitive screening and education quality. Here's what we're going to look at, examine what cognitive screening tests do indeed measure, examine the impact of demographics on cognitive screening scores, black-white disparities on cognitive screening. We'll look at the mini-mental state exam. We'll look at education, more than counting the years, and then we'll look at memory testing, and particularly the fold object memory evaluation. We'll summarize, and at the end, there are some references for you. At the end of today, I hope that the learner will use age and education adjusted norms whenever using cognitive screening tests, understand how the quality of education factors into normative data, and appreciate how expanding cognitive tests beyond screening is often necessary. So what are limitations of screening measures only? Too often, a single score is deified in medical sciences with people with dementia. But let's look at age and education effects. The mini-mental state exam, which has been around for over 40 years, is a great example. Briefly, it measures orientation, registration, calculations, three-word recall, language, and simple construction, copying. If you read some of the normative studies, you'll see that the scoring is 24 to 30 points is intact, 18 to 23 points is mild impairment, and 0 to 17 is moderate to severe. But let's look more closely. For those with 0 to 4 years of education, starting at age 65 to 69, we can see that the mean score of a normative sample is 22, 2 points below the cutoff score. The mean score for those 85 and over is 19, or 5 points below the cutoff score, the most dramatic example of age and education effects. Let's go up the education ladder, 5 to 8 years. You'll still see that the 80 to 84, although the mean is 25, within one standard deviation would get you down to about a 23, which is below the cutoff. 85 is 23, also below the cutoff. So 3 age levels still normatively scoring below the cut score. 9 to 12 years of education. Here we're a little closer, but still the 80 to 84 group and the 85 plus group, even within a standard deviation, would be below the cutoff score. Well, we've known for a long time, as you can see from this study in 1982, that there's high false positive rates in African American elders using the mini-mental state exam. So in this study it was 39%, and all of them that had this false positive had less than 9 years of education. In other words, they scored less than 24 on the MMSE but had no cognitive deficits. Phillenbaum, who's done a tremendous amount of work on this topic down at Duke, noted that, again, the high false positive rate, but also a high correlation of the total MMSE score with education. Well, let's deconstruct race and look at factors influencing rates of dementia as quantified by a screening scale. It's not just quantity of education, quality matters. We're going to look at work from Columbia University and also some of our own Detroit studies. Urban African Americans scored lower on cognitive testing despite equal years of education to white samples. But factoring in quality of education leads to more accurate assessment and understanding of memory and cognitive scores on screening exams. This is just a wonderful picture of a one-room schoolhouse in the segregated South that African Americans had to go to. In this slide, we're looking at what's the length of the school term. And we can see the bottom line is South Carolina black students. Above them in the green triangle is South Carolina white students. You see the same disparity between North Carolina black and North Carolina white as well. Reading ability, what it means and why it matters. Minority elders, especially African American, rural elders, may have more years of stated education than they do skills at that grade level. When I talk about them as rural elders, I'm talking about where they went to their primary school, and often with this current cohort, it's still blacks that were educated in the segregated South and rural areas. Jennifer Manley has done a tremendous amount of work on this topic, and I've given you, at the end of this talk, her 2002 reference from the Journal of International Neuropsychological Sciences. We've also done a bunch of work looking at how reading ability mediates test score differences between older whites and blacks, similar to what Manley has done. If you look at Schaefer-Johnson's study, we looked at a number of different types of cognitive tests, from semantic fluency to different attentional tasks to problem solving, executive functioning tasks, and of course reading scores. In this sample, 73% read below the 12 years of education grade level that the mean score was. So in other words, given their quantity of education, 73% read below that grade level. Only 7% in this sample read above it. You can see here by the percentages that the relationship between years of education and test score is mediated by reading ability. The co-op almost completely, same with Trails B, letter number sequencing, 80%. Only a couple of tests were not related to education at all. That was the animal naming semantic fluency test and clocks 2, which is a copying of a clock drawing that the examiners made. In our follow-up study, we had a little bit higher educated group, 12.8 years of education, 123 urban African Americans. Mean MMSE score, almost 28. In this sample, 45% read below grade level and 25% read above grade level, but we found many similar types of findings. The relationship between the MMSE and education, the correlation was 0.3. It was 0.3 between the MMSE and the reading score, and once you put in the reading score, education years was no longer significantly correlated with the MMSE. It was totally mediated. Once again, that animal naming test was not significantly correlated to years of education. An alternative to the MMSE has been the MoCA, the Montreal Cognitive Assessment. Possible 30 points, has a broader range of items: modified trail making, drawing a cube, clock drawing, 5-item memory test, digit span, repetition, letter fluency, abstract reasoning with similarities, and then delayed recall of the 5 items and orientation. In the normative studies, this was of course done in Canada, that beautifully fell out where the normals were different than those with mild cognitive impairment, who were different than those with Alzheimer's disease. So you can see the average or the mean score, 27 for normals, 22 for MCI, 16 for AD. The cutoff score that was established then was 26, and you could take 1 point off that cutoff score if it was less than a high school education. So let's go ahead and actually look then with this new wonderful test, what happens when you norm it on a more diverse sample in the United States. This sample had many more people, 2,653, over half of whom were African American older adults. Overall, the score was below the cutoff score for the original norms, even when you took away the 1 point for education, and it was 23.4. In other words, 66% of the sample scored below the suggested cutoff. And they failed various things, failed the cube drawing, remembering less than 4 out of the 5 words on second trial, clock similarities, verbal fluency. My point in bringing up the MOCA is that there is no screening test that is exempt from this age and education effect. We have to be very careful not to deify single cut scores based on 1-2 publications or with very homogeneous samples. The second limitation of screening, though, is that memory is not emphasized enough. In order to really assess memory, you have to have a span of items to remember that's beyond what would be just in a primary memory recall, which is 4 to 7 items. We looked at it with the fold object memory evaluation and compared that to the MMSE. The fold object memory evaluation has 10 items that have to be recalled, and the advantage of the fold is that these items are handled, named, and seen so that we know that things are encoded, at least initially. So we had a dementia patient sample and non-demented patient. This was done in the Detroit clinic of the then Michigan Alzheimer's Disease Center back in the early 2000s. We can see that there were significant differences on cognitive tests, both for the mini-mental state exam and for the fold retrieval score. But when we look a little closer, again, we see the MMSE correlates significantly not only with education, but in this sample also with gender and with race, whereas the fold does not. The fold is not significantly related to age, education, gender, but it is a little bit related to race. We look at the clinical utility of these two tests. These are Alzheimer's patients, and so memory testing might give us an advantage, and indeed it does. Overall sensitivity is better for the fold, and specificity is about the same, but if you look at negative predictive power, it's also better for the fold. So overall, using a memory test involved in screening, especially one that is not linked to quality of education, can be very useful in working with African American older adults. Now, more broadly, we want to talk about geriatric neuropsychology assessment. Kind of what is it and what's asked during the assessment process or the interpretation process. First of all, you want to have tests that have normative data on older adults and particularly on African American older adults. So if you look at the MONS, which is the Mayo Older Adult Normative Studies, clinical neuropsychologists in 1992, 96 are both on white samples predominantly, but 2005, down actually the Mayo Clinic down in Jacksonville, Florida, they have an African American set of norms. Spreen and Sprouse have 3 different editions of a compendium for neuropsychological tests. Each test is described, and then you have different normative data that's available. So there are now huge volumes just devoted entirely to normative data, and you want to approximate your sample that you're working with, or your individual, in terms of age, education, and particularly that, but also race if possible. First question that you're asking, is there evidence of cerebral impairment? And this is why normative data becomes so important. We can't compare people often to themselves because they've never had a neuropsychological test before, so we have to compare them to a normative group. What areas of cognition are most affected? So we want to see some establishment of baseline abilities and strengths and weaknesses. How are test results tied to practical recommendations? Diagnostic, independent living, driving, caregiving burden, competency, capacity are just a few of the questions, the practical questions of daily life with dementia that cognitive assessment ought to relate to. So let's take a look at the battery that I like to use. It's kind of a flexible battery. Start off with looking at premorbid functioning, those tests of reading that give us that quality of education and or vocabulary. General tests, the WASI, which is a shortened intelligence test, the Maddest Dementia Rating Scale. These are all really well normed for older adults. Basic and complex attention, visual motor attention, trail making aid, verbal attention, auditory attention, digit span, trails B, complex attention, motor tracking, mental flexibility. Language, we want to look at production, comprehension, naming, Boston naming test, oral comprehension test, etc. For memory, again, we want to look at tests that have well beyond 4 to 7 items for recall. And both the California and Ray verbal learning tests have 15, 16 items respectively. Wechsler memory stories are paragraph-length stories that have about 25 bits of information each paragraph. And the fold object memory examination has 10 items, as I described earlier. We want some visual spatial skills, visual form discrimination, the Hooper, and finally some executive functioning. Letter fluency, Wisconsin card sort, Stroop. These all get at different aspects of abstract reasoning, problem solving, inhibition, disinhibition. Also important to look at things like depression, substance use or misuse, everyday functioning, and where possible, some type of screening for motor skills, finger tapping, or the short physical performance battery. This is what I would call a geriatric neuropsychological evaluation, and oftentimes, even when somebody is scoring in the normal range on MMSE, people with Alzheimer's disease, they will have problems on one or more of these tests, and that's why often we don't just want to use that single number from a cognitive screening exam. Looking though at what's so important for an aging population, cognitive screening and testing, is achieving integrated health care. We are all, who practice with older adults, part of a healthcare team for this older adult, whether that team is recognized or not, whether it's invisible or visible, whether it actually meets together or doesn't. And so when we start to think of it that way, we start to think, well, who are the other providers that are involved in this, and what information can we share and integrate so that we understand best case physical functioning, cognitive deficits, emotional functioning, strengths and weaknesses, and practical recommendations. So communication becomes very important. Finally, I'm leaving you with references for different normative studies, Jennifer Manley's work, and some of our work on influence of reading ability on neuropsychological performance in African American elders.